pulmonary circulation. So over to you, Dr. Rahman.
Hello. Hello.
Yes, you are audible and visible.
Well, good afternoon, everybody. I, as the president of Durgapur Academy of Pediatrics, welcome you all to this scientific session. It is definitely a historical day today because this is for the first time, perhaps, that a WBAP clinical meeting is being organized live from outside Kolkata. I hope it will be a good success, and we will keep on this tradition doing again and again. Thank you, Dr. Shapunra. Please.
So we have got Dr. Joshianand Karketa, the Secretary of the Durgapur Academy of Pediatrics. So Dr. Karketa, just start the program with your faculties in Mission Hospital, Durgapur. Over to you, Dr. Karketa.
Good afternoon, everybody. Thank you, Dr. and Professor Sovan Roy, for giving us this opportunity and helping, I don't know, taking the initiative of, can you hear me, sir?
Yeah.
Thanks for taking this initiative to help us to people working in the peripheries to share their few interesting cases and what are the difficulties we actually face managing these cases in the smaller sub-metropolitan cities. We have Dr. Krishanu with us. He'll be the opening batsman, I think. He will talk to from the intensive point of view. He'll be talking about balancing pulmonary circulations in a newborn. Then we have our enigmatic Dr. Devdeep, always there, working hard and helping us to build up the NICU. Dr. Krishanu is helping, is managing whole of the PICU. So along with that, I'll be sharing one or two cases if time permits. We will be definitely missing Dr. Aritro. He's also not. He's supposed to join. I can't see him on the panel, but we will definitely miss him because he was caught up with his personal endeavors, and so he will not be presenting there. I hope he joins us and gives inputs, and I request all our senior colleagues and teachers to put in their inputs and please share their experiences also, and please give us little tidbits or pearls of wisdom to improve our functioning in these peripheral hospitals. Over to you, Krishanu. I think you take over.
No, actually, our president, Professor Kalpana Datta, has joined. So, with her consent, we'll proceed to the next. So, over to you, Dr. Kalpana Datta.
Good afternoon, everyone. I'm having a very busy and crowdy OPD, even though I've joined for a minute, but I can see many participants, and I expect much more participants to join. Please ask them your PGTs and all to join. And I welcome you all for this second clinical meet of this year, of the first month of 2023, under the chairmanship of scientific chairperson Dr. Shapan Roy. And I think there is a Dr. Sushmita Banerjee is there. So Sushmita, please be a judge because I won't be able to continue very much. Now I'm going to attend one meeting also. So all the best for the speakers and all the best for the mentors also. If I'll get time, I'll join again. Okay. Now I'm going to attend one meeting in the principal office. So please continue yourself and all the best from my side.
Thank you,
Choose
ma'am.
another judge. One is the Dr. Sushmita Banerjee, and you can choose another judge for the this presentation. Thank you.
Thank you, Professor Datta. So I'll request Dr. Krishanu Mondal to start his batting today, and his topic will be balancing pulmonary circulation. Over to you, Dr. Krishanu. Please share your screen.
Is my screen visible?
Yeah. Put it into the full slide mode. Yeah, perfect.
Thank you, Dr. Joshi and ma'am, Dr. Kalpana ma'am, for kind introductions. And and good afternoon to everyone. I want to present a stormy case of meconium aspiration syndrome and pulmonary hypertension. I will be talking about balancing the circulations. And as I will actually present what actually happened in this case. This is a very stormy case, and I will actually present what actually happened in this case and what we actually have done day by day. So this 6 hours old baby was brought with respiratory distress soon after birth, and he was born by LSCS in our peripheral hospital nursing home. And he has a history of dense meconium stent liquor and possible aspirations. Detailed birth record was not available. He had a delayed cry and possible meconium aspirations. The baby was, when he was brought to our hospital, he was found to have grunting and respiratory distress. So he was put on bubble CPAP, SLE bubble CPAP as a standard management. Investigations was sent. It was found that the child was having TLC, a low TLC of 4,400 and a low platelet count of 51,000. CRP was also mildly elevated. Thus, antibiotic was started. But the problem is, after a few hours, the baby started to have desaturations and his distress was more. So we had to intubate the child with a 3.5 millimeter ET tube, and PCV volume guaranteed more ventilation was started with SLE. And volume, we are giving 6 ml per kg, PEEP of 7, and FiO2 requirement was very high, around 90%. Pre-ductal saturation was 90 and post-ductal was 88. So suspecting this is a case, maybe a case of meconium aspiration syndrome and pulmonary hypertension, we have started sildenafil also, and morphine infusion was also started to keep the child sedated. Umbilical venous and arterial lines were put. This is the initial X-ray. After intubations, as you can see, there are dense infiltrates, consolidations in bilateral lung fields, suggestive of possibly dense meconium aspirations. And also you can see the positions of the ET tube and UVC and UAC, they're in the correct position. Echo also, we have done echo. Our hospital has a very good echo facility. So we have, after intubations only, we have done echo. And we have found that there is a large 5 millimeter PDA with bidirectional shunt. And there was a PFO, which was left to right shunting. And TR gradient was 38 millimeter mercury, and there is dilated RARP. So thus confirming our diagnosis of meconium aspiration syndrome and a significant pulmonary hypertension. For that reason, we have started the child on milrinone infusion with a 0.5 microgram per kg per minute, considering dilated RARP and possible RARP dysfunction. And additional sedation has to be given because the child was restless, so midazolam was given. But from day 2 onwards, the baby continued to require very high ventilatory setting with FiO2 of 100%, and with that only SpO2 is only 80 to 90%, and his ventilatory requirement was sky high. Chest X-ray was showing worsening, his counts were declining, CRP was rising. So this is the X-ray on second day, and what it was showing that there is a dense bilateral consolidation, although the lung is expanded by whatever peak, 7 or 8 peak we are providing. With that, the lung is expanded quite, but it is having dense consolidations, and we had extreme difficulty in ventilating this baby now. And as you can see, the snapshot of the monitor of that day. So with 100% FiO2, several episodes of bagging also, we are not able to achieve SpO2, and also his blood pressure was also falling. So we don't know what to do at this moment. We don't have INO. Possibly the baby is having pH crisis with the very dense lung shadow. So we tried HFOB, but due to the logistic reason or whatever reason, it has failed. And echo at that day showing 4 millimeter PDA with complete right to left shunting. Complete right to left shunt, and you can see the blood gas, severe acidosis, both metabolic and respiratory acidosis. So the child was desaturating, is having low BP. We don't know what to do at this moment. So we considered what actually is going on in this baby. As you can see in this picture, this baby is having a bad lung with severe pulmonary hypertension with RA and RV dilated, and with a large PDA communicating between the pulmonary artery and the aorta. So as you can see that there is a septum, ventricular septum is actually deviated to the left side, and there is a very little space in the left side of the ventricle. So what is actually happening is right ventricle and right atrium is dysfunctioning. but he is having very severe pulmonary hypertension, and also because there is a very less space in the left ventricle. Left ventricle compliance is low. That's why left ventricle ejection fraction is also low, and the baby is having low blood pressures. So his blood pressure is low and his pulmonary artery pressure is high. So that's why the PD is communicating between the pulmonary artery and the aorta, and a lot of deoxygenated blood was shunting from the pulmonary artery to the aorta. That's why the baby is having low blood pressures and saturation. So what to do? So we have decided not to intervene the lungs anymore, because the lung is already expanded by our PEEP and whatever FiO2 we are giving. So we were just considering the hemodynamic challenge at this moment. So what we have tried to increase the systemic pressures. That systemic pressures will be transmitted to the left ventricle, and whatever septum is go to the left ventricle, it can push the left septum to the right ventricle, and it can increase the BP. So it's a balance between the pulmonary pressures and systemic pressures. We want to reduce the systemic pressures, and we want to increase the systemic pressures, so that the balance of the circulations can be maintained and there is a less right to left shunt. So for the pulmonary pressures, we have already given sildenafil. Child is on milrinone also, that will reduce the pulmonary pressures, and also child is deeply sedated by midazolam and morphine, and we have done optimum ventilations. But for systemic pressures, we tried different vasoactive agents, and also we were considering sepsis because the counts and other things are very low. So what we have done, we have given the child norepinephrine 0.3 mics per kg per minute. Vasopressin was also started with shock dose because the norepinephrine was not able to increase the BP. So we have to add vasopressins. And for septic shock, we have given 1 dose of hydrocortisone, and antibiotics were upgraded to Elorez, meropenem, and teicoplanin. So with these interventions, with the antibiotic, with the hydrocortisons, with the vasoactive dose in a very high dose, we actually increase the BP in a quite a high level, like 55 to 60 to 65 millimeter per mercury systemic mean BP, and with that amount of BP, his right to left shunt reduced. So now his blood pressures, what we have achieved is 60 to 65 or 55 to 60 actually. So that is more than his pulmonary pressures, and that is maintaining his kind of hemodynamics, and that is reducing his right to left shunt. So with that amount of BP, we will achieve a saturations of 90%, and we can clearly see that when the BP is falling, the saturation is also falling. So day 3, the child continued on the same inotropic requirements with a very high FiO2 requirement. Child additionally has developed acidosis, probably because of some AKI or something. So, and the acidosis is not good for his pulmonary circulations. It can increase the pulmonary pressures. So that's why we have given bicarbonate cannabinoid fluid. We have given Lasix infusions also, and inotropic was continued. So child was a little bit unsteady, but he was more or less maintaining the saturations and blood pressures at a certain level. So from day 4, the compliance mildly improved. So the ventilator requirement a little bit come down. From 100% FiO2, we can taper the FiO2 to 70%. Echo showed mild improvement with RARP dysfunctions, little bit improvement is there. And investigation showed still very low TLC, and the platelet count is only 45,000. So blood culture did not show anything. We don't know what is happening. The TLC is still low. What sepsis we are dealing with, we don't know. So we have added antifungal and colistin, and we stopped meropenem and teicoplanin. So the child is on Elorez, colistin, and fluconazole at this moment. So at this time, a lot of social issues also happened. Father stopped paying at this moment, demanding guarantee that the child should be all right. And there are a lot of threatening calls from the peripheral hospital, from the locality, that the baby is probably dead, and you people are only ventilating the child, extorting money from the family. So what I have to do, I have to call these relatives and all these people to an ICU. And I have demonstrated by doing echo that the heart is beating and your baby is alive. And I have given them hope that probably in another 3 days, the baby will improve, because I'm expecting the pulmonary pressures will fall down in another probably 72 hours. So from day 5, fortunately, there is a substantial improvement in echo parameters with reductions of the RV site and reductions of the pulmonary pressures. So we can taper the FiO2 also, and FiO2 was now 50%. SpO2 is still but blood pressures dependent. So as I am expecting the pulmonary pressures is falling, so I have taken off 2 inotropics, like vasopressin is tapered off and milrinone is also tapered off. But noradrenaline has to be continued at 0.15. The baby is still kept deeply sedated. So this is the X-ray after 3 days of ventilations, after 4 days of ventilations, and you can see that there is a little bit improvement, but a lot of consolidation is still there. Day 6, ventilatory parameters further lowered with a MAP of 9 and FiO2 is now 40%. The vasopressin and milrinone is tapered off, but norepinephrine was continued. TNC and CRP is somehow improved, but platelet count was low. We have continued the same antibiotic. The sedation was tapered and stopped at night and anticipating extubations next day. So day 7, after successful pressure support trial, the baby was successfully extubated. He was put on SLE NIPPV mode, that is non-invasive pulmonary positive pressure ventilations, with 55% FiO2. Noradrenaline has to be continued in 0.1 and 1 unit of platelet transfusion was given. So this is the X-ray after extubation. Unfortunately, after extubation, the child is having a lot of lung cirrhosis. So we don't know what is actually happening with this kid, but we suspected that there may be a PD-dependent left to right shunt, which is happening. Probably that is causing lung edema or some sepsis is there. Fortunately, we were able to manage this extubated baby with NIPPV mode only, with FiO2, with a little bit high setting of NIPPV setting and FiO2 initially. But after 3-4 days, we are able to taper off NIPPV mode and FiO2 was also tapered further. Inotrope was completely tapered and stopped. Feed was built up gradually and full feed was achieved within 3-4 days. Platelet count remained low. Blood culture now showed growth of Pseudomonas species. So UVC and UVC was there for the last 7 days, and probably the lung deterioration was due to this Pseudomonas species. So we have removed the UVC and the injection ceftazidime was started. DPT course or PDA closed. Over next week, the baby was completely tapered from the respiratory support, and with the successful treatment of Pseudomonas species, antibiotic was completed for 10 days, and repeat blood culture was sterile. And after 3 weeks of the hospital stay and stormy course, baby was finally discharged. This is his 2 neurosonogram, and initially when he was admitted, it was having no significant abnormality, and before discharge, we have done a USG cranium. This is also showing more or less normal study. Thank you.
For your excellent case. Now, this is open for any question, and the practitioner is ready to give the answer.
Dr. Roy, can I ask a question?
For sure, please. Please.
Hi, Krishanu. I'm Dr. Saha. Just a couple of questions. Number one is, did we try initially, did we give a surfactant?
No, sir. Initially, we are not giving surfactant. I was considering surfactant, but probably when I got the child, it was actually too late. I got the child after 3 days, so I have not tried that surfactant. And there were a lot of cost issues also there. But initially, we should have tried a surfactant, I think so.
Okay. And the next thing was, I think the baby was never received any paralysis, isn't it?
What, sir?
Paralysis.
The baby with this thing, with the sedations, we are giving good dose of morphine and this thing, midazolam infusion. Child was good sedated. In between, we have given some sedation and some paralysis, but no paralytic infusions. In between, we have to give 1 or 2 times. But when the child was actually desaturating, we have tried giving paralytic agent at day 2 at the stormy period.
You mean no infusions, just stat doses of paralysis?
No, just stat doses. We have given no infusion, no infusion.
And what I see is over 3 days of time, this baby was acidotic, isn't it?
Yeah.
Over the first 3 days, continuously. I mean, and it was mainly, I think the CO2 was never high. It was mainly metabolic acidosis if you look at the gases.
Yes, sir.
So
yes, sir.
We know that acidosis is one of the unless you can correct acidosis, the pulmonary pressures is never going to improve, whatever you try, isn't it?
Yes, sir. Initially,
acidosis was a prime factor in driving the pulmonary pressures, isn't it? So what measures did we take to correct metabolic acidosis? Because the child was well ventilated, I would say, because the CO2s were 50, so that was permissive hypercapnia anyway. So, but the base deficit, if you look at it, but the pH was constantly around 7.02, 7.12. So that wouldn't have corrected the pulmonary pressures anyway. So did we ever consider bicarb infusion or whatever?
So bicarb infusions we have given, and day 2 actually when the child was deteriorating, his P-suit was quite high. But at day 3, I have observed that there is a persistent metabolic acidosis with the base excess around -10. So the cause of probably the child was having low urine output or whatever may be the cause. I have given bicarbonate infusions, and bicarbonate infusions with the mixing of bicarbonate and fluid as a IV fluid. I have given bicarbonate infusions, and with that, actually, acidosis was correct. And with the improvement of the urine output, the acidosis was also correct.
Yeah, I understand that, but you said that you started sildenafil on day 1, isn't it?
Sildenafil on day 1. Second day, I have not given bicarb, but from third day onwards, I have given bicarb infusions.
Yeah, but sildenafil on day 1 without inotropes, was inotropes started at the same time?
Inotrope was not started initially. Sildenafil actually some bolus doses given. Inotrope was given on second day with sildenafil infusions.
Is that the standard practice that we start inotropes, sildenafil before inotropes? Because this is our whole point is to reduce the right to left shunt, isn't it? So you can reduce the intrapulmonary pressures, but unless you are increasing the pulmonary, because if you look at it, the initial TR gradient was about 38, it was not that high. So
Yes, sir, I agree. I agree with that. Probably at that moment, sildenafil should not be given. So when the pulmonary crisis was happening, sildenafil with inotrope should be given.
Okay. Thank you.
Thank you, sir.
May I make a comment?
Please.
Yes, sir.
Yeah. Thank you very much. Lovely case, very well managed despite the hindrances you face from the relatives. I have two small comments to make. One is that the CRP was 19 initially per DL. Are you sure it was DL or was it per liter? Because if it is DL, then it was quite high at that point of time itself. In the first initial CRP, subsequently it was in the 90s and 80s.
Yeah, sir. So 19 will consider it is high, and I think that it is DL. I will check it. So
if it is DL, then because by DL that means that normal is around 1 or 0.6.
Yes, sir.
It becomes quite high at that very point of time.
Yes. Normal value is our normal value. We have given antibiotic at that moment, sir, with 90 milligrams.
So, I mean, I was wondering about your comment that it was mildly raised. At that point itself, it was quite high. If it is 19 per DL. If it's 19 per liter, then it's fine. It's just mild. Second question is, could we have delayed reducing the oxygen supply? I mean, we were having an FiO2 of 100% initially, and oxygen we know is a good pulmonary vasodilator. So instead of trying to rush in to reduce the FiO2s, could we have tried to maintain the FiO2s at a higher level for a more longer period of time, rather than trying to rush the FiO2s? Though I agree that we are worried about ROPs and other oxygen toxicities, but still, could we have prolonged the oxygen giving FiO2 levels at a higher level initially for some more time? That might have helped reducing the pulmonary pressures.
The oxygen was initially started with 90% only, and in first 70 hours, we hardly were able to achieve reducing the oxygen actually. So it was lingering around 90 to 100% only. After only day 3 and day 4, we were able to reduce it, because it was only with 100% also child was not able to maintain saturations. Okay, sir. Thank you.
It was an ideal case for nitric, isn't it, if available?
Any other questions? And any other comment?
I think it was an ideal case for nitric oxide if available, isn't it?
I agree, sir. I agree.
Do you have ECMO, Krishanu, in Mission Hospital? Do you have facilities of ECMO?
Yes, sir. We have facilities for ECMO, but not neonatal. We have done ECMOs in one child who was around 14 years old.
Okay. Thank you, Dr. Krishanu Mondal, for your excellent case. Now we'll move on to our next case. So Dr. Devdeep Mukherjee will be presenting not turning a blind eye. So Dr. Devdeep.
Yeah, good afternoon, sir.
Good afternoon.
You just had a power cut, so I guess we'll have the generators up. So till then, it will be quite dark as I speak. Thank you to West Bengal Academy of Pediatrics for giving us this opportunity. And I believe in the days to come, the residents of this region will also get sufficient ample opportunities to present their cases. I have got a couple of cases. There's nothing quite heroic about them, but they are very basics. But it's basically to do more with a proper history taking and clinical examination, which gives us cues to have a diagnosis and then plan a management of these cases. So both of them are to do with neurology and a bit of neurosurgery. So the first one is actually not turning a blind eye. So we had this 14-year-old female child who was previously fit and well. So a male child who was previously fit and well, and then started having blurring of vision and headache for a period of around 14 days. He was also having a low-grade fever of around 100 to 100.6 for 7 days. The parents had done some blood tests outside, and he had normal counts, normal platelets. CRP was around 26. He had a Vidal, which was negative, malaria and dengue, which were negative. He was also reviewed by his ENT surgeon for his headache and was diagnosed as migraine, and he was on flunarizine for the last 10 days. He also had an ophthalmology review, and which was considered to be normal with normal refraction. On day 15, he tripped and he fell and then parents decided to bring him to our hospital for further evaluation. So he came on day 16. He was having a persisting headache. He was also complaining of painful eye movements on that day. And he had a pediatrics and a neurology review at a hospital, and a WBAP was done, which was suggestive of optic neuritis. A MRI brain was normal, but the MRI orbits were suggestive of bilateral optic neuritis. So here there were a bit of dilemma with regards to the initial diagnosis with a headache and difficulty of vision. But then further radiological and VEPs picked up the diagnosis of optic neuritis. What was essential was to find out the etiology behind this, because that would suggest the course of treatment and the further diagnosis and prognostication. So he was hospitalized for finding the etiology and for running medications and treatment, as was the etiology which we could decipher. So there was no past history of similar illness in this child nor in the family. He had an incidental ureteric stone for which he was being followed up by urology. He had a GCS of 15. He was conscious and alert. He had normal power, reflexes, and muscle tone. His finger counting for his left eye was 1 foot, and for his right eye was 2 feet distance. He was otherwise hemodynamically stable with no other neurodeficit. We ran these routine investigations and a few other special tests, which included ruling out autoimmune phenomena. So we sent an ANA profile. We did vitamin B12s, VDRLs. We thought about looking into the MOG antibodies, because this is one of the new things in adolescent kids. We also thought about sending an NMO antibody. We did a CSF study, which I'll put up the reports in the next few slides. And we also checked for HSV PCR as well in the CSF. He was still having a slightly higher total leukocyte count with a neutrophil of around 80% and a CRP of around 16. CSF showed 20 cells with 90% lymphocytes, protein was 87, and glucose was 78. So with the diagnosis of optic neuritis and pending the reports of ANA, MOG, and NMO antibodies, we started him on methylprednisolone of 1 gram for 3 consecutive days as per the optic neuritis treatment trial protocol. And then we switched over to oral prednisolone of 1 milligram per kg per day for 14 days, followed by a slow taper. In this period, we had the results back. So the ANA was negative. The NMO antibody was negative. The MOG antibodies from CSF was negative, but the MOG antibodies from serum was positive. So this gave us a diagnosis of myelin oligodendrocyte glycoprotein antibody associated disease. So with ongoing steroids, his vision improved and he had a bilateral visual acuity of 6/9. He had a relative afferent pupillary defect, and then we gradually switched over to tapering doses of steroids. As is the usual course, whenever there is a difficult diagnosis, parents decide about seeking opinion and treatment elsewhere. So they went to Niemann's, and where he had a repeat course of pulse methylprednisolone. But by then he had already achieved some improvement of vision. So this was around 1 month of getting discharged from our hospital. Then he had a longer duration of tapering prednisolone of another 3 weeks. He was also given 2 doses of rituximab as per Niemann's, although We could not find any treatment protocol for MOGAD where at the first instance, rituximab has been considered. But the diagnosis was reconfirmed. The antibody was positive in the serum. So once with steroids and 2 doses of rituximab, there was considerable improvement, and he has been well in follow-up. So this was the MRI of the brain, which was normal, which actually was done to rule out any evidence of ADEM as well, which is often associated with this form of antibody-associated disease. The MRI spine was also reported to be normal. There was no involvement of the spine for this child. And then if you look closely at the center of the orbits, you'll see areas of hypomyelination. So which gave us the diagnosis of optic neuritis for this child. So there was a minimal thickening of the left compared to the right optic nerves with mild central hyperintensities in the bilateral optic nerves in the anterior two-thirds of the intracorneal part. The posterior part, which was in the optic canal and the optic chiasma and the optic tracts were normal. The signal changes were best seen on the T2 images of the coronal images of the orbit. The optic nerve sheath was found to be normal. So what is MOGAD? It's quite a new entity, diagnosed in around 1990s. So this was an inflammatory disorder of the central nervous system, which is characterized by attacks of immune-mediated demyelination, predominantly targeting the optic nerves, brain, and the spinal cord. And the disease has a predilection for children, usually in the second decade of life. So it might involve the white matter with a presentation very similar to multiple sclerosis, optic neuritis, or there might be evidence of myelitis. When it involves both the white and gray matter, there can be a presentation like an ADEM or a lipodystrophy. If it involves the gray matter, there can be cortical encephalitis, or it can overlap with features of NMDAR encephalitis. It can also involve the meninges and might have a presentation like an aseptic meningitis. So this child had 20 cells in his CSF. And when it involves both the gray matter and the meninges, it might present as a meningoencephalitis. So optic neuritis, unilateral or bilateral, causing visual loss, often with optic disc edema. ADEM leading to altered mental status in conjunction with features of transverse myelitis. It might present as a transverse myelitis, often causing limb weakness or numbness with gallbladder and sexual dysfunction in adults. Or there may be cerebral cortical encephalitis with headaches, seizures, and focal neurologic deficits. So evaluation MRI helps. The routine ophthalmology review was normal because it does not look into the optic nerves. The serum testing for MOG antibodies is what is diagnostic. The CSF MOG antibodies are usually negative in this case. However, the oligoclonal bands might be present in around 10 to 12% of the cases. For our child, this was negative. So in terms of the MRI with optic neuritis, the orbital MRI typically shows a unilateral or bilateral gadolinium enhancement involving more than 50% of the nerve with predilection for the anterior optic pathway. With an ADEM phenotype, the brain MRI usually reveals features like ADEM with multiple large, poorly hyperintense lesions in the white matter, deep gray matter, brainstem, or in the cerebellum. There might be presentation like transverse myelitis or, and the most T2 hyperintense MRI lesions in the brain and spinal cord of patients with MOGAD resolved completely during follow-up. So the serum antibody has a high specificity, but false positives can occur and oligoclonal bands can be seen in 5 to 20% of the patients. So this was the report for myelin oligodendrocyte lipoprotein antibody, which was positive for this child. So the difference or the differential diagnosis are with aquaporin 4 associated NMO and with multiple sclerosis. And you can see the difference from the pictorials. For MOG, there is a bilateral involvement with more than 50% of the optic nerves involved. And it's usually the anterior optic nerve pathway with optic disc edema. For NMO, it's more of the posterior optic pathway and the optic chiasma. And for multiple sclerosis, it's usually unilateral with less than 50% of the nerve involvement when it's related to the optic nerve. In terms of the spinal cord, for MOGAD, there may be multiple lesions with central cord and conus medullaris involvement. For NMO, it's usually a single lesion. The central cord is involved. The cervical or the upper thoracic are much more common than the lumbar segments. And for multiple sclerosis, it's multiple lesions, as you can see on this image over here, with short segments and the periphery of the cord are involved. And in terms of the brain, for MOG, there will be fluffy diffuse lesions in the white matter or in the deep gray matter, brainstem, and in the cerebellum. For NMO, it's a confluent asymmetric lesions in the subpile and the periappendicular regions, brainstem, hypothalamus, and the corpus callosum. And for multiple sclerosis, it's actually cortical or the juxtacortical or the periventricular lesions. So the take-home message over here, history taking is very important. So this child was in a difficulty, but it's the fall and trauma which actually made the parents aware that something wrong is going on over here. Appropriate investigations are often necessary. The ophthalmology review or the refraction was normal, but the VEP and the MRI clinched the diagnosis. We should also look for lesions in other sites for such antibody-associated disease. So if there are problems in the eye, we should screen the brain and the spinal cord. We should try and rule out common differential diagnosis. We were fortunate enough to be able to send these high-end investigations, but not always that's possible. But again, it helps in arriving at an etiology. So treat aggressively and treat early for antibody-associated disease. So it's around 1 year at follow-up, and the child is reasonably well with almost normal vision in both eyes. There hasn't been a relapse, although the relapse rates are around 40 to 60% for MOG-associated disease. And there is often, there are data which has shown that they have even progressed to overlap syndromes like an NMO-associated disease over a period of time. We were thankful to our neurologist, Dr. Snigdhendra Ghosh, and our radiologist, Dr. Kapisur Singh, who were extremely helpful while we were managing this child. Thank you.
Thank you, Dr. Devdeep, for your excellent case, and it's very unusual. So now it is open for any question or discussion. Anyone?
Can I ask a quick question?
Yes, ma'am.
Sure.
They've really very well picked up and very nicely worked up case. So I think you mentioned that if we had not done the VEP in this patient and had just done a MRI brain, this optic neuritis would have been missed. Is that correct?
Yes, because there was nothing in the brain. It was there in the orbits. So if you couldn't have looked at the orbit specifically, there was a possibility that this could have been missed.
So you have logged in by the two device, I think. There is a lot of echo. Please switch off from one.
I have just one device logging in.
Okay, a lot of echo is coming. Anyway,
so some amount of the orbit is seen in MRI, isn't it? And
yeah, but I think people are very specific about what they want to look at. So I think specifically, I don't think the radiologist usually look into structures because to be very honest, when we had the optic neuritis, I remember discussing with an ophthalmologist, and he was quite sure that which was there on the VEP was not significant for this case, and he did not even want an MRI orbit at that point. It's just that a neurologist stressed on the fact that we need to do a MRI orbit for this child, that we went ahead and got it reviewed specifically.
Okay, so I think that's a very important thing for all of us to understand. It's not something that we would specifically often ask for. And second question is, in the long-term follow-up, do these children need to continue on immunosuppressants so that they do not get relapses?
No, there isn't any data about continuous follow-up with immunosuppressants. But yes, relapses usually do occur even after 10 to 15 years. That's what the data shows. But again, it's quite a new entity diagnosed sometime in 1991, 1992. So there is still not enough data or evidence as per what kind of immunosuppressants might be given. There was a bit of data about rituximab for relapses, but here we found nuance going ahead and giving rituximab at the first instance itself.
And can you titrate, like according to your antibody, does the antibody become negative once you've treated? And can you sort of titrate your immunosuppression according to your antibody positivity, like in some autoimmune diseases?
So they are following up with Niemann's, but they do visit us. We haven't seen them repeating the antibody levels yet again. So yeah, and because it's quite costly, we haven't asked them to repeat the test.
Thank you.
Actually, Devjit, if you have done the retinoscopy. Retinoscopy revealed optic neuritis. So you went for the MRI of the orbit. And Percy, you have taken advantage of doing this MRI brain as well as the MRI spine, spinal cord, because you want to exclude the transverse myelitis also. And by repeating the same test again, I think it will definitely involve a lot of money, and that is not possible in our setup. Anyway, fantastic case, and you have gone through these investigations and you got the diagnosis. So can you please proceed to your next case?
Yeah.
The looks can be deceptive.
Yes. The next one again. Just a second. The next one again is very similar. So so again, there is a lot of examination on history taking which is involved. So whatever we see inside is not what is there outside, or it's the reverse way over here. So that is what is interesting about this child. So this was a 12-year-old female child who presented to our outpatient department around.
Are you speaking with your earphone?
No, sir, nothing. Just
there is a lot of echo coming. Lot of echo coming. Come closer to the laptop, I think that can solve.
Is it better now?
Yeah. Please.
So this child came to our OPD around 1.5 years back. So there was a history of an on and off back pain for 1 month. She was slightly obese, but there was no history of fall and trauma prior to this episode. She was also complaining of sudden onset bilateral lower limb weakness for around 3 days prior to visiting our hospital. There was a difficulty in walking due to weakness and pain in her lower limbs. And for the last 2 days, she was having urinary retention. So the last 3 days history of weakness and the urinary retention made the parents extremely worried, and they decided to bring her to our hospital. On examination, she was found to have hypotonia with diminished deep tendon reflexes in her lower limbs. She had grade 2/5 PAR in her hips and 1 in her knees and ankles. Her tone PAR and reflexes in the upper limbs were normal. There was no evidence of breathing difficulty or a nasal intonation of voice. So there was no recent history of fever, diarrhea, or vomiting prior to this episode, and there was no history of similar illness in the family. So this was at around, I still remember, this was around 4:30 in the evening. So with the history of lower limb weakness, there was always a possibility. And with the neurological examination, we felt that this might be GB syndrome. So we thought that before our lab closes at 5 o'clock, we'll get our NCV done so that we can think about starting appropriate medications. So the NCV was suggestive of motor axonal neuropathy. The routine biochemistry was within normal limits. So until then, we had not examined the back of the child. A 12-year-old female adolescent wasn't very comfortable with us examining after undressing her. So with the initial NCV, we were thinking whether we should start immunoglobulins, but then we thought that we'll just complete the examination and have a look at the back because she was complaining of pain. So on examination, it revealed a pigmented nevus in her lumbar paraspinal region. Was this significant at this point? Possibly not. But then we thought about going ahead and doing an MRI of the spine. The sagittal T1 and the T2 images showed acute to subacute hematoma in the dorsal epidural space in the lumbar spinal canal, causing severe canal stenosis at L23 level, extending up to the L34 levels. Interesting. And then in the axial images showed dilated vessels in the right lumbar paraspinal muscles with extension through the right neural foramina into the spinal canal. So this was actually an acute to subacute hematoma in the dorsal epidural space, causing a lumbar canal stenosis. So the MRI actually showed a posterior spinal canal acute epidural hematoma with a neural compression. And there was a lumbar paraspinal vascular malformation, which was seen extending into the extradural space and the right L23 and L34 foraminas. So the following day, she underwent an emergency L1 to 4 laminectomy and a decompression of the extradural hematoma. And during surgery, what was noticed was a large abnormal dilated vascular channel, which was actually crossing obliquely through the spinal canal, causing the neural compression. So this was excised and sent for biopsy, but while this was being done, there was quite a lot of blood loss. The paraspinal vascular malformations were not targeted surgically at that point then to avoid further blood loss, and the technical challenges of the elastic vessels of a large vascular malformation that retract and bleed from tissue depths were avoided at that point. So the immediate post-op course, there was some improvement with all the decompression that had been done, and the patient started improving neurologically. She had some improvement in the power in her lower limbs, which was now 3, and her pain also subsided to some extent. However, she was still having this voiding difficulty, and she remained catheterized. So the child was taken home against medical advice by relatives at that point due to logistical reasons. They also wanted to explore treating this child in northern India. So they went to AIIMS, where they stayed for 2 months at Safdarjung actually, because they could not manage a bed at AIIMS. And when she wasn't improving with a similar condition, they decided to come back to our hospital after 2 months for further treatment. A digital subtraction angiography was done at that point, which delineated the architecture of the spinal vascular malformation, and there was a large venous set having multiple arterial feeders from the right side of L3. So the anterior spinal artery was seen from the left L1 level. So subsequently, we had interventional neuroradiologists from INK coming over to our hospital. So Dr. Purakayasto with his team came to our hospital along with the neurosurgery team. They successfully embolized the spinal vascular malformation with glue. Following this, there was gradual improvement of motor function, and over the course of the next 1 month, she started walking. She was troubled by a nagging allodynia and a radicular pain along the lower limbs for the next 2 to 3 months, which started subsiding after embolization. So at 1 year after spinal decompression, which is actually 2 months back, she is presently able to walk at normal pace. She has resumed school, where she was not going for close to 8 to 9 months. She does have mild residual hypertonia of the left lower limb, and she walks with a subtle limp. There is no pain, and she's off all medications, and she has also regained bladder control. So spinal vascular malformations are a complex entity and rarely noted in children. The incidence varies from 3 to 11% and varies across all age groups. It's commonly seen in the elderly with a predilection for the thoracolumbar region. If not detected early, they can lead to spinal cord compressions, as we all know, urinary retention, bladder bile incontinence, or erectile dysfunction in adults. They include capillary telangiectasias, cavernous malformations, AV malformations, and AV fistulas. They have varied age of presentations, different clinical features, and different radiological appearances. They can be intramedullary, perimedullary, extradural, or radicular, depending on the location, or depending on their flows, they can be high flow, low flow, or those with no AV shunts, depending on the flow pattern. In children, what we see more commonly are the high flow SVMs, and they are predominantly congenital lesions, as we saw in our child. So they may be detected incidentally, which happened in our case over here, or they may present with hemorrhage or mass effect, as we saw in our patient who presented with a radicular pain, hypotonia, and urinary and bile retention. There can be increased spinal venous pressure leading to venous congestion, which in turn reduces the drainage of the spinal veins, contributing to progressive myelopathy Angiography is the gold standard, and treatment involves surgical approach, embolization, or a combination of both. So the take-home message over here: a focus on a good history and proper clinical examination. Just because the investigations suggest something, we shouldn't get biased by them and not complete the set of investigations that is needed to arrive at a proper diagnosis. Do not hesitate to get an imaging of a spine done if dealing with a case like a GB syndrome, as we have seen often. Correlate history with clinical findings. A spinal AVM is extremely rare, but is not uncommon in children. And a multidisciplinary team approach of neurosurgery, where we had Dr. Das and Dr. Kulsa from our team, Dr. Ashok Bharati, our radiologist, who picked up the MRI scans early. And then we had Dr. Shukalan Purakaistho and Dr. Shubhrata Nag, our neurointerventional radiologist from INK Kolkata, who were kind enough to come over to our hospital to help this child. Thank you.
Again, another excellent case from Mission Hospital, presented by Dr. Devdeep Mukherjee. Now, this session is open for any questions and any discussion. So, Bivan, please proceed. Bivan, you can carry on. I can see your thumbs up.
Well, I was just telling him, I think it's the constellation of cases that we get. It's nothing. I think no comments, because I think it was excellently managed, I would say. I mean, based on the history and how the investigation proceeded, I think it was excellently managed. No comments, actually. Well done. Well done.
And hats off to Dr. Shukalan Purakaistho. He has come all the way from INK Kolkata to Durgapur Mission Hospital and did these embolizations. This is a fantastic case. So, any comment from anybody? Any questions or any comment?
So,
I think everybody has become speechless. Thank you, Devdeep, again for your excellent presentation. Now we'll move on to our next case. It will be presented by Dr. Joshi Anand Karketa. It is beyond bronchiolitis, a brainy tool.
Can you hear me, sir? Hello?
Yes.
Can you hear?
Yes.
Thanks, Dr. Krish. Thanks, Dr. Krishanu, and thanks, Dr. Devdeep, for the wonderful cases you presented. I'm just after both of their extraordinary cases, just two simple cases. I don't think if I get time, I'll present both of them. Is my slide visible?
Yes, please go for slideshow. Right.
Yeah.
Right.
Okay, we have Okay, we have I have a small 4-month-old girl presenting to our hospital emergency with cough, cold, rhinitis, and then later for past 4-5 days, and then later developed breathing difficulty and apnea, just like any other bread and butter case for all the pediatricians. This child was thought to have bronchiolitis and was admitted because they had feeding difficulty and was lethargic. The child was born at 35 weeks to an IVF pregnancy mother, and it was delivered by LSCS for PPROM, and the birth weight was 2.34 kgs. The baby at presentation had a history of partial head control. Social smile was there at 2 months, but had not yet started rolling or turning over. Baby was mostly on breastfeeds, on occasional formula feeds whenever the mothers were traveling. There is a history of little feeding difficulty and noisy breathing. There was no any other abnormal history of any abnormal rashes or abnormal urine. Stools were normal and initially, but now because during the cough and cold period, the child was having little cough, mucoid stools. On examination, if you see, temperature was just marginally elevated. Respiratory rate was high. Saturations were 94% in room air. Was having a noisy breathing. Didn't look dysmorphic. Cardiovascular system examination appeared normal. Air entry on examination of the chest was equal on both sides. There were a few crackles heard. The thing was noted was the child was hypotonic and had a head lag. If you look into that growth chart, you'll see both the height, weight, and the head circumferences were much below were on the nearer the third centile. This was the X-ray, nothing very significant. Little prominent thymus and bronchovascular markings. We thought it was bronchiolitis. X-ray, because of the stridor, we did a lateral X-ray, which didn't show anything much. Investigation showed we did a VBG, not very, just like a mild respiratory hypercarbia was there. So we started on, because of the distress, child was started on HFNC. Count showed hemoglobin was 9.9 with almost normal differential and total counts. Platelet count was normal, electrolyte normal. The CRP was elevated. Blood culture was done, and the child was started on antibiotics. Liver function tests were not very dramatic. Uric acid and LDH, because of the stridor, we had sent a calcium, uric acid, LDH, and lactates. All seemed normal. Echo done later on the next day was came down as normal. Calcium, magnesium were also normal. So we started the child on fluids and nebulizations. Because of the distress, was started on HMFC and nasogastric feeds. Because of the high CRP, initially was just managed with nebulization, but cefuroxime was added. A little scared with the high CRP. Child became well, and the child was slowly tapered off from the nebulizations and the HFNC. And the sister was recorded this video saying that this child is having some abnormal movements. If you look at the eye, there was some abnormal movement, but the child otherwise appeared normal. There was no distress. And there was little bit of apnea, but not much of importance was given at that time. Anyway, the child parents wanted an early discharge, and since the child was feeding well and there was no distress, the child was discharged and sent home. The child was fairly doing well till about the next few days and maybe months. During the hospital, this is what we retrospectively, this is what we had seen. In between, the child was actually having dips in the oxygen saturations. And in between, mother used to always ring up and tell me the child was having episodes of noisy breathing, sometimes used to choke while feeding. But I told it'll settle down, you come and show. They didn't come back for almost 2 to 3 months. And child later on, after 2 months, they brought the child again around at 8 months of age with this sort of breathing. The child was having little bit of stridor, but otherwise child was feeding well. So because of the delayed developmental milestones, I started getting worried. Am I missing something? Echo done earlier was normal. The child was just having a stridor basically at this time. So looking into all the causes of stridor, I started ruling out each and everything. The X-ray lateral didn't show anything much. There was no history of this child was no history of foreign body. Got a repeat echo done. These are the things I started to rule out. So next, what to do next? Do I do because of stridor? Do I do a overnight oximetry? Do a head ultrasound? But with the anterior frontal lobe was very small. I tried to do it. It was not very good. Because of the hypotonia, do I go ahead with a MRI of the brain, or do an EEG to make sure that I'm not missing subtle seizures or something? So after a little bit of thinking about, I got this study in which was published by Voter et al. In Head and Neck Surgery, which says that if you have an abnormal neurological finding, this child had hypotonia and mild developmental delay with a history of choking and feeding problems. If you have all this, the chances the MRI will pick up the findings is very high. So I did a MRI, and unfortunately or fortunately, you see, I got this MRI. For me, it didn't make too much of a sense. So discussed with our radiologist, and they showed this MRI to me. Does anybody know what it is? I think this is what
molar tooth. Yeah.
Yeah, this is very good, man. I didn't know this is the typical molar tooth appearance. which is very, very
Joubert
suggestive or almost diagnostic of Joubert syndrome.
Joubert syndrome.
So I just presenting this case because it took me almost 3 months to diagnose this case. Had I been little bit more alert, picked up, taken the sister's finding of breathing difficulty along with tachypnea much earlier, with the hypotonia, maybe I would have done the MRI earlier. So basically, this case is it is a simple case of stridor, which we normally think it is only the airway. And coming to this is called Joubert syndrome. It is quite a rare disorder, but now people with the NGS they find that it is much more commoner than that. It can be as less than in certain Ashkenazi Jews and the Hitterite populations. They have found that it is as common as in 1 in 300 live births. First described by Mary Joubert. It has to have a triad of hypotonia, molar tooth sign, and developmental delay, which all of these three things were actually there in my child. But just because that my mind did not know, I didn't pick it up earlier. It is classified in the group of something called ciliopathies. Basically, all this, I'm not going to detail to bore you with all these things. Basically, any protein related to this ciliary function, that is the microtubules, which we always read about in our Cartagena syndrome. This cilia actually helps in the transfer of signals from extra cellular space or from the outside to the inside. So this helps a lot in giving the direction, left and right direction, the coronal differentiation of which cells to go where. So it can affect anywhere. Initially, it was thought only to affect the brains. That is why MRI was initially suggested. But since the CDI is present in almost all the organs, it can affect any of the organs and presenting at different ages, depending on whichever gene is affected. So these are the number. All the genes, around 35 genes have been identified, and the type of Joubert syndrome. That means whether it's associated with the kidney, liver, brain, depending on the type of mutation, it is affected, and the chromosomal location has been also given. So what are the things actually we should look for? Basic things in a peripheral, what we should actually look for is if the child is having any abnormal eye movements, whether it's having periods of apnea and hyperapnea, which I actually thought was initially periodic breathing and just underruled it. And almost all of them, if you look into the study by Maria et al., almost 100% of them have hypotonia. So if a child has got abnormal eye movements with hypotonia, with respiratory problems, the chances for that child to have a Joubert syndrome is very high. This study by Dempsey et al. In 2017 have followed up almost 21 children with Joubert syndrome, and they have found that initially in the first in the infancy, usually it is the respiratory problem followed by the renal and the liver problems. 1 to 5 years, it is basically the respiratory failure starts settling in, and afterwards it is usually the kidney and the liver problem which starts to take over about 5 years. So if a child has got snoring, apnea, tachypnea, and has something like a TTN at birth, chances for you to have Joubert syndrome is very high. Like what I said earlier, it can affect any of the organs, right from the eye to the fingers and the toes. They have polydactyly, syndactyly, they have midline defects. They can affect almost all the body parts or organs. So they have classified this the Joubert syndrome depending on the type of presentation. And if you have a molar tooth sign with the CNS defect and eye, kidney, liver involvement, you are relatively sure that it is a Joubert syndrome. Management wise, if they're having apnea, you can try caffeine, but it is not very well evidence based. If they have tachypnea or if they have stridor, you can give them low flow oxygen. Sometimes CPAP or the BiPAP will help. In very severe cases, tracheostomy may be also required. Things to be remembered is you should avoid opioids and try to use regional anesthesia if any surgical procedure is attempted. So this child actually is on follow-up. The child does not have at present any eye involvement or liver or the kidney involvement. Ultrasound of the abdomen does not show any cysts. Liver is, LFTs are all normal. Just following it up, the opthal examination shows early changes of optic atrophy. Baby is at present feeding well, growing well. So this is just my take-home messages with that Joubert syndrome, though it is quite uncommon, can be easily picked up by just remembering that if a child has got, or in the infancy there is hypotonia along with breathing problems and feeding problems, we should always do an MRI. Other features of eye, liver, and other things can be involved. Though there is a whole list of organs involved with Joubert syndrome. So if we look for them, it will be there. But what I want to highlight is what the mind knows. Until the mind knows, the eyes will never see. With this, I think I will close this short case. I'll go over to the next case after the, if there are any questions anybody want to ask.
Thank you, Dr. Karkit, for the excellent case. Though nowadays we are getting Joubert very much. Last week I got a case over here, the Joubert syndrome, but there was a midline defect in the form of encephalocele in my case.
Right.
So, are you going to present the other cases?
Yes, sir.
So please.
So another case was a 4-month-old child who was first born third degree consanguineous marriage. This child came to us at 9 months of age with the same problem of stridor. This was the first child born out of LSCS. There was no history of any NICU admissions. Developmental milestones initially were normal. The social smile at 2 months, had control of 3 months, and there was no other significant family history. At 9 months of age, child were presented to us with respiratory distress, noisy breathing, just like the other case with stridor. There was a history that the child had seizures at around 6 months of age, and after this seizure, the child lost all miles. Whatever the milestones were there were all lost. There is no history of any recurrent fever, cough, cold. Child has been feeding well. There's one history of nebulization in the past, because had some history like a bronchiolitis. On examination, if you look, the child is very happy, cheerful. We can't make out anything, was playing. Just a mild stridor was there, minimal subcostal retraction. There was no organomegaly, no seborrheic dermatitis, alopecia. Ataxia was there slightly. Tone was increased on all 4 limbs. Deep pendant reflexes were brisk. Plantars were extensor, and the pupils were reacting to light. So based on this, I thought probably it is just a mild, simple case of stridor. Just to be on the safer side, to do echo, chest X-ray, and just to make sure the calcium and the electrolytes and the blood gases were normal, just to make sure that there's no features of hypocalcemia. So did the X-ray. X-ray was relatively okay. There was no cardiomegaly. Echo done was also normal. Child was started with IV fluids and some adrenaline nebulization, thinking that it might be some sort of acute laryngotracheobronchitis. Child was given 1 injection dexamethasone, and amoxicillin 1 dose was given just at the time of this one. But since all the reports were normal, we stopped. So electrolytes were normal. Venous blood gas was also normal. Hemogram showed anemia. Calcium, magnesium, all were all okay. Ammonia, lactates were all normal. And since the child was doing well, didn't do anything. But because of the history of 1 episode of seizures at 6 months, loss of milestones, the tandem mass spectrometry, and that means the newborn screening, and then 1 MRI was done. MRI brain was normal. EEG was also normal, and eye checkup was also normal. So I was just stuck what to do. Anyway, the stridor improved after supplementation with food and after the nebulization. So thought it was just a mild acute laryngotracheobronchitis, and I sent them home. But they came back after 1 week with a tandem mass spectrometry report showing that the child had severe, profound biotinidase deficiency. So this case, I just wanted to say that not all cases of biotinidase deficiency present with seborrheic dermatitis with or alopecia or with skin manifestation. So it can be just that they can present with seizures and hypotonia. And looking back, did a PubMed search, and definitely there were a few case reports of biotinidase deficiency presenting with stridor. So not all stridor is actually airway related, and just started the child on biotin, and all the problems of the hypotonia activity, all that improved, the tone improved, and child is now around 1 year, 1 month old. Child is able to sit, crawl, slightly delayed, but we should remember that biotin will give will almost give recovery to almost all the neurological problems. Even the seizures might disappear, but the optic atrophy might persist. So we should diagnose biotinidase deficiency as early as possible. And some children, we should remember that they might require long-term treatment with biotin. I think with that, I will end these two cases of stridor, that we should not only think about airways. Thank you very much.
Dr. Karkit, but you have done the MRI. In MRI,
yes, sir.
In diffusion weighted image in biotinidase deficiency, there is a remarkable change that
yes,
you can get. Possibly the age of the child is not enough. He was infant, no? 4 months.
Yes, sir. It was done around 6 months of age.
6 months.
May have been
there are specific MRI changes in the brain in the biotinidase.
Yes, sir. Yes, sir.
Particularly in the brainstem, the middle cerebral peduncle, the splenium of the corpus callosum, and the posterior limb of the internal capsule. There are a lot of case reports also.
Yes, sir.
When any question from
saw
anybody?
That the MRI can, if you do the MRI properly, there might be changes in the.
Yeah. I think if you do it at 2 years of age, I think some finding will be evident.
Yes, sir.
So now this forum is open for discussion. Any question? Please stop sharing.
Can I make a comment?
Sure.
Yes, sir.
The best part was that we had both ends. We've had rare cases, that means the one really rare, and we had not so rare cases, but I mean rare presentations of common cases by Dr. Karketa also. So wonderfully done. Excellent. Nothing more to add. Great.
Thank you, sir. Thank you, sir.
Dr. Karketa, can I ask something here?
Yeah.
Yes,
please,
sir.
Dr. Shah, please.
Hi. Because I've got 2 cases of Joubert which are under my care, which was diagnosed quite early in life as well. So my question was, first question is, the stridor that you found, do you think it was just due to hypotonia of the vocal cords?
Yes, sir. It can be it could have been because of the hypotonia of the vocal cords. Plus, I discussed with the ENT people. They are saying that this child's MRI, the fossa posterior, the cerebellar vermis was very, very underdeveloped, and they had a large cisterna magna. It looked almost like if somebody doesn't know too much of radiology, will take it as an Arnold-Chiari malformation or this one. So that can cause a little bit of a stridor.
Yeah. So that was my thought basically. So prior to going to MRI, if we are thinking of a stridor alone in a 3-month-old or 4-month-old where stridor is not recovering, I think the confounding factor was the initial bronchiolitis. But
yes, sir.
Would you have gone for a DLTB first before going to MR?
Yes, sir. We could have done, but we don't have those facilities here.
Yeah, because I know this is because this MR has given a diagnosis. Suppose
Yes,
MR
sir.
couldn't give a diagnosis. I think the pathway. I mean, I would have tackled it differently probably. I mean, you got the diagnosis. I think it's retrospective now, so it is difficult to say, because this could have been something different, isn't it? Hemangioma of the upper airway or something like that. I think the confounding factor was the bronchiolitis and the hypotonia, which probably pushed you to do an MR first.
The only thing was that this child was having hypotonia and developmental delay.
Yes, that's what I'm saying. So
anyway,
hypotonia probably was the confounding factor which made you do the MR first, probably, isn't it?
Yeah.
Yeah, and my only other thing is because both of my these patients are now about 5 years old, because we know their life expectancy is about 6 to 7 years in these children anyway. So both of these patients are on currently are on home overnight CPAP here currently.
Yes.
Because of one of the main, they have apnea of at night usually, and we don't really know how, and they die of respiratory failure in the long term, isn't it? So do you have, what is the long-term prognosis? How do you manage these patients in the community now?
Yes. Literally, I don't have any experience till now. This child is fairly doing well. I think it is must be very, very minor sort of very uncommon mutation. They have told them to do a NGS, but it is not done. But till now, this child is absolutely okay. Other than the developmental delay and the hypotonia.
Yeah, but this will set, I mean, this will start.
But it will definitely progress. I think it will definitely progress. So just keeping
my question was, is there any facility in the community to facilitate these basically in long term?
Home CPAP, we have tried for a BPD patient, but not for such a bigger children. So.
Okay, thank you.
We have one case in ICH, central hypoventilation syndrome. We have tried with this home device of this. Dr. Prabhas Boshan Giri has
there is an interesting news article published from Mumbai, where some Dr. Prem is doing stem cell therapy for these Jubers, and one of those children has improved. I don't know how scientific or how evidence this is, but there's a small case report in the Indian newspaper of stem cell therapy for Jubers.
Yeah, stem cell therapy in muscular dystrophy is also coming in the horizon. So any other questions from anybody? I think it was a fantastic presentation by Dr. Krishanu Mondal, Dr. Devdeep Mukherjee, and Dr. Joshi Anand Karketa. So I'll request Professor Kalpana Datto to conclude the session if she is there. I think she has left. So over to Dr. Sushmita Banerjee. Please conclude. The ex-vice president, ex-president of WBAP.
Thank you, Dr. Shapan Rai, and thank you to this whole team from Durgapur Mission Hospital. I think all of us have really enjoyed the cases, as Dr. Arun Manglik has also mentioned, starting from the rarer manifestations of common illnesses to the very, very rare diseases, and really very well worked up, excellently managed. And I think most important, showcasing how we can all, ask each other for help, and how teamwork really takes us forward. So congratulations to Durgapur Mission Hospital, to WBAP team of this current year. And I hope this is the start of many such exciting clinical case presentations and meetings. Thank you.
Thank you. So we close the session. Thank you. Thank you.
Thank you, sir. Thanks to WBAP for giving us a chance.
Somnath, can we get this YouTube of this one?
Already.
Okay. Thank you so much. Bye.
ক্লোজ করছি। আপনি একটু সবাইকে বলবেন যাতে সাবস্ক্রাইব করে, তাহলে পরের এগুলো অটোমেটিক্যালি নোটিফিকেশনটা চলে যাবে। তারা যদি ভুলেও যায়, লিংকের নোটিফিকেশনটা চলে যাবে।
ওকে ওকে ওকে
ওকে, ক্লোজ করলাম।